following oral administration. Stereochemistry. Meso compound usually contains two or more identical substituted stereocenters. So it has two stereocenters which are identically substituted. So if you have a CH2, you have a CH2, CH3, let's say CH2, CH3, CH3. The other carbon has, it's still a chiral center, but it has the same group CH3, CH2, CH3. So the two centers are identically substituted. So the two carbons are similar. So they will be superimposable, as we have said. It has an internal symmetry plane that divides the compound in half. The two halves reflect each other by the internal mirror and are superimposable. The stereochemistry of stereo centers should cancel each other out when there is an internal plane that splits the compound into two symmetrical sides. The stereochemistry of both left and right sides should be opposite, and therefore the molecule will have no optical activity. And I've given, I think, a simple example for us to understand what we are talking about. I've just given a very simple example here where you have this molecule. You see this carbon here has an OH, a chloro group, and a hydrogen. It is a chiral center. Then you also have this as a chiral center, which has hydrogen. So the substituent, so this carbon and this carbon are basically the same, but one will be R, the other one will be S. So now, if you have this internal, so you look at this is a plane which we are drawing here. We are drawing our mirror. We are putting our mirror here. If this is a mirror image, but this will just lie on the other one. The OH will come there, the hydrogen will come there, the Cl will come there. So they are superimposable. They're superimposable. They are mirror images, but superimposable. And all we are saying is that the stereochemistry of this will cancel the stereochemistry of that, or the stereoactivity, whereby the optical activity of this will cancel out that of the other one, and therefore the molecule basically will have no activity, or we have no stereoactivity. So I gave as an example of something perhaps which is a bit more easier to understand, and I hope you understand. All we are saying is that when you talk about mesoisomers, it is where the two carbons, if you're talking about two or two chiral centers, it's where the two different chiral centers carry the same substituents. And if you establish the internal symmetry where you're going to put your mirror, you can put the mirror in a position where the two portions on the same molecule are superimposable, and because of that, the molecule will not have any activity. Remember, for molecules, optical activity, they cannot be superimposed. They will have there will be mirror images, but one cannot be superimposed on the other. I believe you know that already. Then we're looking at the SAR, and we are saying those molecules are usually not changeable. It's usually found, it's almost a fixed molecule, does not allow for any structural modification. Most of the structural modification will result in loss of activity or decrease. The presence of the two amino moieties is essential for antimicrobial. Remember, this antimicrobial is not just ordinary antimicrobial. We should put it more correctly, antimicrobacterial activity, or anti-mycobacterial TB. In fact, need to be very careful. We put antimicrobacterial TB activity because, of course, we do have leprosy and also TB. And, of course, this drug has no activity against leprosy, antimicrobacterial TB, or antitubercular. You can even put as correct activity. Presence of small branch alkyl groups on the nitrogen atom also increase on the activity. The small alkyl groups, if you look at both of the presence of small alkyl groups and the small active alkyl groups on each of the nitrogen are ethyl groups. On each of the nitrogens, ethyl groups have been substituted, and they were found to increase or improve on the antitubercular activity when the amino moieties were replaced by either acetyl, sulfonyl, or nitrosyl moieties. Antimicrobacterial activity was abolished. So we are therefore saying the amino groups are also necessary for activity. Change usually brings loss of activity. Also, when heteroatoms such as oxygen, sulfur group were substituted in the ethylene moiety, inactive derivatives were obtained. So again, it was not possible to add any heteroatoms within the molecule. The molecule seems to just have to be the way it is for us. When hydroxyl groups were replaced with either methoxy or ethoxy groups, equipotent activity as that of the parent hydroxyl group was obtained. This is the only change that so far we have seen, that you can replace the hydroxyl group with either methoxy group or ethoxy group. But if the hydroxyl group has good activity, why bother with a bigger group, which will be more expensive to add? And that is why Ethambutol has the hydroxyl group. You can replace it, but replacement will lead to equipotent molecules, or lead to drugs which are equipotent and therefore no added advantage. And of course, as I have said, having the hydroxyl group is much cheaper. Replacement either by benzoyl, thiomethyl, the hydrazine also results in inactive compounds. So what we are saying is that there was no significant change, no significant structural modification. No structural modification can really be done on Ethambutol to give a significant change in antitubercular activity, and therefore no wonder the Ethambutol was the best molecule for activity. We are saying that group must be there, that group, the alcohols must be there. They can be changed, as we have said, to methoxy group, but the resultant molecule will be equipotent with Ethambutol, so no need for change. Those small groups, the alkyl groups, were also important. They were found to increase activity. The amino groups were also necessary. The alkyl group there was necessary, and therefore that molecule was best suited for activity. Ethambutol in this particular class of drugs was found to be the best, and was responsible for optimal activity. What is the metabolism? And as you can see, when you look at Ethambutol, we have said it has the butanol, so it has an alcohol. Alcohols are normally metabolized through oxidation in the body to the aldehyde, and then the aldehyde undergoes further oxidation to give the carboxylic acid, and that is how, again, Ethambutol is metabolized. So remember, this was where you had the CH2OH. Here we had the CH2OH. So the alcohol is metabolized through alcohol dehydrogenase, and the alcohol dehydrogenase will give us the aldehyde, and then the aldehyde through the aldehyde dehydrogenase will give us the carboxylic metabolites. And this metabolite, having two carboxylic groups, highly water soluble, readily removed from the body. Again, remember, whenever you increase the water solubility, then the drug just diffuses back into the blood and is removed from the body. So the metabolism of Ethambutol is through oxidation of the alcohol to the aldehyde and ultimately to the carboxylic acid. Normally use the dehydrogenase enzymes for the oxidation to give us the dicarboxylic derivative, and the dicarboxylic derivative is readily removed from the body. The synthesis, again, I'm looking at the synthesis of this drug because it is easy. Synthesis of this drug, again, is easy. We are starting with the 1,2-dichloroethane, CH2CH2 dichloroethane, and we are adding or condensing it with 2 molecules of 2-amino-butanol. 2-amino, you can say position 1, position 2, position 1, position 2, position 3. So you can see it's this position 2 which has the amino. That's why we are calling it 2-amino-butanol. But one of the things we have said is that this must be resolved. The 2-amino-butanol must be resolved, so that we want that 2-amino-butanol give us the dextroisomer. Because remember, we do know the methyl isomer is much more has much less activity compared to the dextroisomer. So indeed we want the dextroisomer, and indeed it's the levoisomer, which is the R-, actually is highly toxic. It causes blindness. So you want to resolve the so that the reagent that we are using is the one which will give you the dextroisomer. Because once you get the dextroisomer of ethabutyl is the one which is responsible for optimal activity. As I have said, the levoisomer actually causes blindness. So ethabutyl can never be given as a racemic mixture. Cannot be given as a racemic mixture. You want it to be given as a pure isomer, which is a dextro, the S, the dextroisomer, of course, is the dextrototally S isomer, which is responsible for maximum activity. Mesoisomer has much lower activity, and as we have said, the levoisomer, which is the R, which has the R configuration, causes a lot of toxicity, which we are talking about blindness. So it is prepared by first dissolving the racemic 2-aminobutanol vitacerate, and the positive enantiomer is condensed. So it must be the positive, the dextro is condensed with 1,2-dichloroethane in a suitable dihydrochlorinating atmosphere, and then whatever you get dissolved in appropriate solvent and treated with hydrochloric acid to obtain the official compound. Of course, you can see the official compound is a hydrochloride salt. So this point, very important, you must resolve that reagent so that you only use that which is responsible for giving you the dextroisomer 1, so that you maximize on the activity and minimize on the toxicity, because as we have said, the levoisomer is highly toxic. It brings about blindness. It is an odorless but bitter, freely soluble in water and alcohol, and slightly soluble in chloroform. Adverse effects: optic neuritis, resulting in decreased vision and loss of ability to differentiate red, green colors. So you see, I think there is a time I was watching a certain movie, and there was somebody who was very malicious. The way people just poison these. Sometimes in homes or in families, sometimes the wife wants the husband dead. The husband wants the wife dead. So there is somebody who used ethabutyl, and it was very serious. Of course, finally to kill. But one of the problems, of course, is that you fail to be able to differentiate the colors. You can see you have no loss of ability to differentiate red, green colors, and because we are saying it is causing optic neuritis, it can even cause blindness. It causes actually blindness. So you can imagine that. So we are saying, again, a very important drug. When you give the patient, you must sometimes and that's why we said you have a special clinic. That's why we also ask that there should be pharmacists in all these clinics, because you can be able to tell the patient, just in case you take the drug and you find that you're having an issue with your eyesight or even in differentiating colors, please stop the medication and come back to the hospital. Those are some of the things that are information that is very important, so that they do not, because sometimes you can still get toxicity. You can get high, you remember, because of the storage of these drugs, because sometimes of failure to follow the proper SOPs. When you go to the industries, you see some of this. Sometimes they don't follow the SOPs to the letter. So because of those failures, you might still find that the drug is contaminated with more. You see, the contamination of the levoisomer might be there, but it might be limited. It might be very little. So because it's very little, it cannot cause any toxicity. It cannot reach the critical dose to cause toxicity. But when it's above certain levels, because perhaps of issues of storage, issues of manufacturing, where the SOPs are not well followed, then you find the drug can cause a lot of toxicity. And once it does so, of course, you can cause a lot of toxicity and, of course, a lot of danger to our patients. Therapeutic uses: it is a first-line drug used in the treatment of pulmonary extrapulmonary TB. It is used in the prophylactic treatment of TB at a dose of that. In the combination therapy of TB, it is given along with isoniazid, pyrazinamide, and rifampicin for 48 days for initial therapy. So again, as we have said, these drugs, they are not very safe. They have a lot of toxicity. But I said, and I will stress it again, sometimes the patient doesn't have any other hope, because failure to take the drugs, as we already know, also will mean death. it is where the patient really doesn't really have any other choice, but of course to be well informed. To be well informed, they deserve free information, good information, whereby they know how to use these drugs well and to detect any extremes toxicity, and they can be able to report the same to the nearest center or to the nearest health center, and perhaps you can have a change of drugs, or the drug can be checked onto whether it the quality standards or not. Mode of action: it disrupts the arabinogalactan synthesis by inhibiting the enzyme arabinosyl transferase. So this one acts differently from the other ones we're looking at, and we are only saying that when you have the mycoric acid, it still has an effect. It doesn't affect the mycoric acid directly. The mycoric acid will be synthesized, but this mycoric acid, which is synthesized, as we had said earlier, is supposed to condense with arabinogalactan. It is supposed to condense with arabinogalactan at the 5' hydroxy group. And all this drug does is to prevent that condensation. It prevents the mycoric acid from binding the arabinogalactan. Failure to bind the mycoric acid fails to bind the arabinogalactan. Failure to bind the arabinogalactan means you are not going to form your mycorrhizal arabinogalactan complex, and that is the complex you require for the integrity of the cell wall for this microorganism. So the mode of action is a little bit different. Remember, for the others, it is inhibition of synthesis of mycoric acid. For this one, the mycoric acid is being synthesized, but remember, when it is synthesized, it must interact, it must bind, it must join with those other complexes within the cell to form the ultimate, the final, very rigid complex, which is responsible for its integrity of the cell wall. So now it blocks or it inhibits the enzyme, which we are calling arabinosyl transferase. So therefore, the mycoric acid does not bind the arabinose. It does not join the arabinose within the arabinogalactan. Don't form the complex, cause meaning death or suppression of the microorganism. So mycoric acid attached 5' hydroxyl groups of D-arabinose residues of the arabinogalactan and to form the mycorrhizal arabinogalactan peptidoglycan complex in the cell wall. Disruption of the arabinogalactan synthesis inhibits the formation of the complex and leads to increased permeability of the cell wall. So this ethambutol causes inhibition of the mycobacterial arabinosyl transferase. Of course, the mycobacterial arabinosyl transferase involved in the polymerization reaction of galactan. So the mycoric acid is supposed to join arabinogalactan to give you the polymer, which then joins the peptidoglycan to give you the ultimate complex that is responsible for the rigidity or the integrity of these microorganisms. So once you give this drug, it blocks the enzyme, and therefore there will be disruption of the complex and increased permeability, which may result to suppression or death. Again, we had already talked about the synthesis. This is the same thing. We had already talked about that. Pharmacokinetics. It is well absorbed from the gut. It is well distributed throughout the body. Peak levels that it can cross the blood-brain barrier when the meninges are inflamed. Remember, when the meninges are intact, very few drugs are able to pass. But when the meninges are inflamed, quite a number of drugs are able to pass through the membranes, and therefore, when it is inflamed, 20% of the metabolites are excreted in feces and 50% excreted in the urine. We've already mentioned the route of metabolism of this drug is just through oxidation of the alcohol to aldehyde to carboxylic acid. Ethambutol is found to be more effective against Mycobacteria tuberculosis, and also that it can be used for tuberculosis meningitis, again, because it is penetrating the meninges. But of course, also we have to be careful of its adverse effects, because fever and skin rashes It may cause optic neuritis and reduction in visual acuity. It may also cause a loss of red and green color discrimination. This we had. So it is having a negative influence on visual acuity. It has visual acuity and color discrimination. So that again can be quite a problem. Green, because those are the primary. I believe those are the primary. I hope they are the primary colors. So it can cause a problem there, and definitely with the eyes, anything that interferes also, anything that interferes with any part of the body in a very major negative manner is not a good drug, because any of the body organs are very important. So that again is the end of, look at this thing. That is the end again of the Sabuton. And let's see if we have questions. Any questions? So that is the end of the Sabuton. Again, I told you here, and that's what to me makes this unit a little bit easier. They are just, of course, there are many drugs, but the drugs are much simpler. They have, most of them have really no structural connection. They are just individual drugs that were discovered to be effective against the mycobacteria tuberculosis. Again, we are always remembering that this is a complicated microorganism. It has a very complex cell wall, so the drugs you give must be able to penetrate this very complex cell wall. And hence, of course, I think that is why we have very unique drugs. We have very unique drugs, not very many, but we have very unique drugs that must be able to do the same. So from that, the next category of drugs that are used against tuberculosis is the rifamycins. Again, at least the rifamycins are a group of drugs. They are a group of drugs. They're actually antibiotics that are naturally occurring, and because they are naturally occurring, remember when we were doing the antibiotics, I believe we did mention most of these naturally occurring drugs usually occur as mixtures of, they can be mixtures of different compounds, but the different compounds are differing very slightly. Remember when we were talking about cephalosporin, CP, and so on. So they differ very slightly. Only a small portion of that compound is different. And then out of that mixture, sometimes you find one of them has good antimicrobial activity. One of them has good antimicrobial activity, and therefore you pick the one with good antimicrobial activity. You study it for its shortcomings, and you see whether you can be able to do any to get a molecule that is more superior in terms of its properties, in terms of its characteristics, in terms of its toxicity, in terms of its effectiveness. So, but more often than not, the original molecule, like for antibiotics, is naturally occurring, even as we did for Pen-V, Pen-G, and so on, naturally occurring, but it has its own shortcomings and therefore need to structure and modify. So these rifamycins are also naturally occurring, but they have their shortcomings and therefore need for structural modification. Family of closely related antibiotics, including rifamycin A, B, C, D, and E. The only component of this mixture which was sufficiently stable to isolate in pure form was the rifamycin B. So rifamycin B was able, but after, of course, in special conditions of synthesis, they were able to get the rifamycin B, but unfortunately, it is poorly active. Rifamycin B, which is essentially inactive, is again spontaneously oxidized and hydrolyzed in aqueous solutions to use the highly active rifamycin S. We're going to look at their structures. So the rifamycin S was found to be more active. Simple reduction of, again, rifamycin S yielded the hydroquinone form called rifamycin SV. So already we have talked about rifamycin B, which is a starting point, then which changes to rifamycin S, and then rifamycin S changes to rifamycin SV, which became the first member of this class to enter the clinical use as an intravenous antibiotic. So rifamycin B, rifamycin S were not really used. SV was one of the first one, but you can see, of course, the challenge is the fact that it must be used parenterally, and not just parenterally, it has to be used intravenously. Of course, you have done routes of drug administration, and you know the dangers of IV use, the costs, implications, and of course, the dangers that can occur. Further chemical modification of rifamycin SV yielded an improved analog like rifamide, which was also introduced into clinical practice, but was still similarly limited to intravenous use. So here we have mentioned, we have started with B, we have gone to S, we've gone to SV, and we have gone to rifamide. And all the need for the structural modification, all the changes, some of them occurring spontaneously within the mixture, but some, of course, being brought about by organized change or planned structural modification to give you a molecule with better activity. In all the ones that were developed still had the challenge. They still had the challenge of the fact that they had to be given parenterally. So before we move on, let us look at these structures. So this is the basic structure. This is our basic structure. This is our basic structure here. Let me see whether I can, yes, yeah. Make it a bit bigger like that. Go on down, down. So when we look at, so this is our rifamycin moiety. The area of difference, you can see this R1, I hope everybody can see that R1, and you can see that R. So this area and this area in the whole of this big molecule, this is the only area of change. So even when sometimes you are being requested to discuss and you are given the structure, normally nobody bothers. I would not bother to draw the whole of this structure here, this area here. I will only draw this area and give you R and R1, and then show lines to show that the molecule is extended that way, because the whole of this area, which we are saying is the hydro, if you look at it, it is a side chain. So this is the side chain here. So the whole of this area does not change in the rifamycin. What changes is that R and R1. And when we look at this molecule, you can see we have this aromatic center here, aromatic center there, and then it's joined. You can say a portion this aromatic area is joined. That you can go round, come round, come round, and come back there. So you have that hydrophobic group with a very small, very few water soluble molecules. So it's mainly a lipophilic group. If you look at this group, mainly it's a lipophilic group, but it does have areas of hydrophilicity. And as I have continued to say, any drug for it to have activity, it must also have some water solubility. So if you look at this area there, it is joined with that group going around there. And such drugs are given, I wanted us first to look at that, and such drugs are given a certain name. Go back. Yeah, there we are. So when we look at rifamycins, this is what I was showing you. You have that aromatic area. The aromatic area can be structurally modified. That's why I've put an R there. The R can represent another aromatic ring, like, of course, for the rifamycin, you have two benzene rings fused together, and of course you have other substituents. So that's why you have an R there. But we are talking about this side chain, which joins different portions of the aromatic center and joins the way it is. The way you can see how it is joined. And therefore, we say that because of this kind of structure, we say that rifamycins are classified as an ANSA. And I don't think there is A. A is not there. It's ANSA, ansamycins. What to your A? Ansamycins. So they are classified as ansamycin, and a structure with an aromatic moiety spanned by an aliphatic bridge. Therefore, their answer compound. So if you look at, and I've just shown you, I will not go back there. So if you look at that structure which I've shown you, you have the aromatic center, which is usually a naphtha ring, and that naphtha ring is joined at two different portions by a different structure or by an aliphatic bridge. So you have an aliphatic portion that joins two different portions of the aromatic center, and that is a compound you call the answer compound. So that's what I've said. You have that aromatic ring and you have this aliphatic bridge or aliphatic side chain that joins the aromatic group at different positions. That's what you call the answer compounds. Answer compounds, they can be benzene derivatives having para positions or meta para positions or meta positions, either para or meta, bridged by a chain which is commonly 10 to 12 atoms long. Commonly 10 to 12 atoms long. By extension, any arene bridged by a chain constrained to lie over one of the two faces of the arene. So it's constrained, it comes, so lies, it goes from one side to the other, and you have the aromatic area joined by a bridge. That is indeed what you call the answer compounds. And we can see when we look at the rifamycins, they qualify to be answer derivatives because of that kind of bridge or that kind of aliphatic chain, the kind of aliphatic chain that you have that joins the same aromatic ring at different positions. So it's joining the same aromatic ring at different positions. I think there's something I've lost.